Amy, I'm going to mess up your last name because I do every time. So I'm going to let you go ahead and introduce yourself. You have lessons learned to share with us as well. So go ahead, Amy. Thank you for presenting for us today.
No problem. I'm Amy Krupa. I am the Pediatric Emergency Management Coordinator for the Oaklawn campus of Advocate Children's Hospital, which is just outside the border of Chicago. We're literally blocks away. We are a children's hospital that's attached to an adult hospital. We share the same campus. So we had kind of a unique response from that perspective to begin with. In general, we have 2 Gen Peds floors and then 2 ICUs, one's cardiac and one's just kind of all comers ICUs. And at the onset, we designated one of our floors to be the COVID floor. So they got all the PUIs, persons under investigation, and then all of the positive patients went to that unit unless they needed ICU care, in which they went to our general Peds ICU. The cardiac ICU actually doesn't have any negative pressure rooms, which was a whole separate learning note for everyone. So they had to go to the general ICU. And then we do have a large and almost 60-bed NICU as well, and took care of COVID positive moms. Their neonates were separated as long as moms were agreeable and went to the NICU. I think one of our big ones for peds was that because of the volume for us, all of our rooms are private, which was huge. So we didn't have any, cross-patient contamination there. And we were able to, because of the smaller volume of peds patients, designate one-to-one nursing care for all of our COVID positive patients. So there was no crossover. If you were taking care of a COVID positive patient that day, you didn't have any other patients, unless we did have a couple times in the ICU where they had to double up, more than one positive for that nurse. But in general, we were able to, protect patients that way by not crossing over staff who had taken care of COVID patients. That was really nice. And it was something we kind of recommended the adult counterparts when they were trying to decide, are we going to close COVID units or share, mix COVID positive and COVID negative patients on the same unit? We kind of recommended that same strategy, and that's actually what they did in the adult ICU. They had a COVID side and a non-COVID side, and designated staff that don't cross over between the two. In general, we have a total of 38 COVID positive patients that we've seen either in the ER or admitted to the hospital so far, which is about 6.5% of what the adults saw. So definitely a much smaller volume, even though it still feels big for us. We did also have 7 children that got treated for MIS-C, 2 of which were actually COVID positive, and the majority of which actually had antibodies to COVID but weren't testing actively positive on their PCR. We did see, in addition to those, frankly, MIS-C patients, we saw a fair amount that we were concerned about MIS-C and they didn't end up testing positive either on antibodies or on the PCR. And so then they were just kind of hanging out with no great diagnosis there. We had 54 neonates that were born to COVID positive moms, so a big group of them as well. And none of those were positive on testing. We based our testing for neonates on the AAP guidelines there. So they got tested at 24 hours and then either 48 or 72 hours of life, depending on when they were anticipated to leave the hospital. So big wins for us. So our emergency operations center is shared between the adult and the children's hospital. And we had a designated pediatric representative to that group all the time. So that was a big win for us. It made one person to kind of bring problems who could then take it back to smaller work groups. We also monitor everyone in the hospital 24/7 with a strike team for COVID response. And we started that, our medical director of disaster medicine started that almost immediately. Once we started to see a little uptick, it wasn't just the ER, it was more patients that were COVID positive. So if you got a test for COVID in our hospital, this centralized team was aware of your presence, following your results, making sure, the appropriate people were notified, getting you moved to the COVID unit. And we still have that team operational 24/7 at this point. We generally run 1 to 2 nurses and 1 physician in 12-hour shifts with that. So that's been amazing as far as coordinating educational responses. Initially, those teams were doing a lot of the swabbing in the early days, and then we kind of backed off of that and did a lot of teaching for the units, but we still provide support, answer questions, discuss changes, and all that comes through our strike team. I implemented pretty early as well. We did kind of weekly Q&A sessions. It was meant for the general staff more than the leadership, but we still get a lot of leadership asking questions to let people really, I have a question about this. This is a problem on our unit, specifically for pediatric, to kind of, let us know what's going on in the unit. What are the, we keep running out of wipes every day, and then to kind of take those, either answer their questions or to problem shoot and bring that forward for things to work on during the group. And the team really seems to like that. There's people that call in every single week because they just want to, hear what questions people have and, hear about what's going on. So that's been really, really well received by the team. We had, we shared actually our PZR. We have separate PZR that has 22 beds, and we shared back to the adult side with that. We shared 12 rooms with them to give them some more volume, especially when they had a high amount of distressed patients coming in. And hopefully we're transitioning soon back to not having to share. And then our PICU actually shared, they took patients on ECMO who were COVID negative. We used 9 of our 24 PICU beds at one point for those patients to kind of help offload so they could actually take a higher volume of COVID positive ECMO patients in the area. And then we had almost 3,800 staff that were redeployed in separate instances, whether it was to temp taking stations, to helping adult units, to assisting employee health. We had a huge number of staff that were redeployed, and they were pretty excited to be able to do that with some coaching. We did use the team nursing method. So there was a primary nurse from that unit who was responsible and kind of the knowledgeable, worked on giving medicines, and then the team nurse from another unit helped with kind of all of the other changes, so I'm not responsible for the epi drip if I don't know what to do with that, but I can certainly do a basic assessment on you, make sure you're getting turned, help with other care that those patients need. So we felt that worked really well for us, and staff were satisfied with that. Challenge-wise, visitor restrictions was a little bit of a challenge. We do have seasonal influenza restrictions that run in the fall, but there was some dissatisfaction with parents with being told, only one parent is allowed to visit at the bedside. We weren't willing to go, no parents at all. We didn't feel like that was appropriate for pediatrics. We did also have some issues prior to using universal masking at the hospital. We did have issues with parents not conveying that they were symptomatic or had been tested and were waiting for their test results, and that resulted in some exposures on our end. And then we had some staff who were like, oh, I just thought it was my allergies, had really mild symptoms, and ended up with some exposures from that as well. There's not, other than universal masking, which is what we do now, all of the providers all the time have to wear a mask in the hospital. And then we offer masks to visitors and patients in shared spaces. You know, there's really not a lot to do to prevent, you know, just reminding people, you know, if you're symptomatic at all, like, please stay home, let us know. Don't, you know, don't take one for the team here. That's not helping your team at all. Some other challenges, frequent changes to the guidelines. We did have this managed through our hospital system, and guideline updates tended to happen really sporadically, especially late on Friday or Saturday nights when it was difficult to communicate out to the rest of the team members what this change was, when it was taking place. We've recommended, you know, kind of going forward, that we tell the team, okay, all the changes this week will happen, you know, you'll hear about them on Monday, and then they'll go in place on Wednesday or whatever day we kind of decide to pick. That's definitely been a recommendation. A lot of the frequent changes in PPE resulted in some mistrust with the organization for team members, feeling that they just couldn't, you know, like, we're not being honest about what's going on, what the level of PPE is here. So I'm getting the high sign from Christine that I talked too long, I think.
Amy, you're great. I just, you definitely went over, but all of your information is super important. And I also noticed that you answered one of the questions that came within the chat box within your presentation as you were going. I don't know if you intentionally did that, but it was just very smoothly done. So impressed by that. Did you have anything? I didn't want to cut you off completely. Did you have other things that you wanted to share?
I think our kind of our big one that was really fun for us was that we actually did a magnet visit for our first ever, the adult hospitals, and we used to share in that, are certified for magnet, and this was our first application for magnet as a children's hospital alone, and we did the first virtual visit with them 2 weeks ago. So that was really cool to be able to figure out, you know, how that's going to work all remotely with the team. So we're really proud of that and excited to hear what the outcome will be.
That's awesome. Good job. Very impressive. Did anybody else have any other questions? I see that Dave Reddick is asking for all of the presenters. He'd like to know if they knew then what they know now, what one thing would you do differently? So Amy, since you're on right now, I'll let you answer that one, and then we'll come back to that for the rest of the speakers because we do have one more presenter.
I think for me, it would be that, you know, communication about when things are changing, from how things are being handled in the organization, to really streamline that and to be able to give leaders a heads up about what's happening before the rest of the staff gets messaged, and to be consistent about how that happens.
Thank you, Amy. Thank you for presenting. We appreciate your willingness to share. We have one more, Dave McGraw.